Welcome, everybody, to Grand Rounds. Thanks for those of you who are in the room. As usual, if you're online, I'll be watching the chat for your questions, and make sure you stay muted. And today I get to turn things over to Dr. Lori Ruttman, who's going to introduce our lectureship and our speaker for today. Thank you so much.
Thank you, Suzanne. So I am so excited for this Grand Rounds today, and it's really my pleasure to introduce our speaker. This Grand Rounds is being co-hosted by the Department of Pediatrics and the Center for Quality and Patient Safety here at Seattle Children's Hospital. We brought in Dr. Andy Beck to do a QI Scholars session with our scholars yesterday, which was phenomenal, and are thrilled that he's able to stay this morning and also do a Grand Rounds. I think you're all in for a real treat to hear about his work and the really exciting applications of geomapping in neighborhoods to population health. Dr. Beck is a professor of pediatrics at the University of Cincinnati College of Medicine and an attending primary care and hospitalist pediatrician at Cincinnati Children's. He's director of population health, health equity research, and innovation, and a faculty co-lead for the community and population health within the Cincinnati Children's Office of Population Health and the Michael Fisher Child Health Equity Center. He received his BA in anthropology at Yale, his MD from the University of Pittsburgh School of Medicine, and his MPH from Harvard. He completed residency and fellowship training at Cincinnati Children's. His research aims to equitably improve child health outcomes by addressing neighborhood influences through clinical community partnership. Again, it's my real honor and privilege to introduce Dr. Beck.
Well, certainly thank you for that introduction and for having me here today. It's really exciting to be here, and it's always fun to visit the Pacific Northwest. So it's pretty here. I really enjoyed kind of walking all around the city and seeing all that it truly has to offer. And that conceptually for me is, I think, relevant to the discussion today about the relevance of neighborhood, of place, and the sense of community that yields to population health outcomes for kids. So I wanted to start by just identifying some practice gaps that ideally will start to fill during the course of this hour. One, that there is this fundamental imbalance to how health systems address both medical and social determinants of health. And the imbalance then propagates persistent inequities that exist across ages and conditions. I'd also suggest that silos will often stand in the way of members of a broadened system focused on health, enabling collaborative efforts that move in the direction of more equitable health and well-being. And that health largely is experienced outside of healthcare settings. So we all work in healthcare settings, but the actual influences on health generally occur in places that are beyond our walls, that could promote or impede the outcomes that we're striving to obtain. And so with this in mind, some goals for today are to examine the concept of neighborhood and their link to our sense of community, to illustrate the importance of neighborhood and community to a range of pediatric outcomes, and then to close by formulating some approaches to neighborhood-based action, engagement, and improvement, which can truly move us in the direction of the outcomes we seek. So I'd like to start with this conceptualization of neighborhood and community. What do we mean by these terms? What do we mean by the way in which they can influence the health of our patients and the populations we serve? And I'll start with some definitions. This first definition for neighborhood comes from the Department of Health and Human Services, where they term neighborhoods as the places where people are born, live, learn, work, play, worship, and age. And I ask you to remember that phrase because it will come back to us in a moment in another definition that I'll share. And the map on the left part of this slide, I suppose it's your right, depicts Seattle neighborhoods. And I imagine many of you could look at this map and say, I live here, this is what characterizes that particular neighborhood. My patients live here, this is what characterizes that particular neighborhood. Now, neighborhoods are important. They are the places where people are born, live, learn, work, play, worship, and age, but they are connected to this concept of community, which is defined by the Centers for Disease Control and Prevention as a specific group of people who share a common culture, values, and norms with relationships that are developed over time. So it's the way in which many experience the neighborhoods on a day-to-day basis. So I ask somewhat rhetorically, what does neighborhood or community mean to you? To what neighborhoods or communities do you have meaningful or perhaps emotional connections, and why? And I'll just highlight a few of the ones where those connections are meaningful for me. I grew up in Brighton, a suburb of Rochester, New York. I went to college at Yale and Ezra Stiles College, a residential college or dorm within that university, provided that sense of community for me. I long visited Squirrel Hill in Pittsburgh when I was growing up. That was where my mom was from. That's where I lived when I was in medical school. That certainly had a sense of meaning for me. And then Montgomery is a suburb of Cincinnati where I currently live, where my kids are going to school, all places that are meaningful, impactful, and relevant to the health and well-being of me and my family. But the very true reality is that neighborhoods do not always promote community. They're not always idyllic. They're not always welcoming or inclusive. They're not always on the receiving end of investment or opportunity. And it's the balance of a neighborhood's assets and risks that could influence health and opportunity outcomes for their residents. And so with this in mind, we recently posed the question to our patients and their families about how they view their neighborhoods, the sense of community that those neighborhoods served to promote or impede. And to do this, we asked them a simple question. Could you draw a picture of your neighborhood? Could you illustrate how you view your neighborhood and how it affects your health and well-being? And so I wanted to share a couple versions of what we got. This is one example. There's Mitchell Avenue, one of the streets within Cincinnati. You see a couple houses, some nice trees. You see the nice little family there. And overall, this looks like a rather pleasant place to be, a place that perhaps serves these kids quite well. Another rather positive example, some of the text might be a little bit hard to read, but you see a bunch of houses close together. You see some nice grass. You see people saying, thanks for the lookout. There's a job fair. Welcome to the neighborhood. Again, kind of positive sense of community between residents of this particular neighborhood. But clearly not all neighborhoods and not all pictures that we got were positive. Here's another example. This is a picture. You see 3 cars going down a street, some houses and a stop sign in the vicinity. In the bottom part of the screen, you see Wild West. And then on the back of this picture was written, shooting during the day, used to the sound of gunshots, people speed by the house in a drag race. So that's in essence what this is showing, illustrating the experience of neighborhood, the experience of place for one of our patients and their family. And then a last example here, which shows the proximity of neighborhood to our hospital. You see a number of buildings that are marked Children's. Those are Cincinnati Children's buildings, our hospital, some outpatient buildings, some office buildings. And in close proximity to those, you see, I wish I could go outside. I wish the killing would stop. I'm afraid to go play. The bottom, there's drugs being sold. Move out of the way. There's a shootout. So this is the lived experience. This is the neighborhood in which many of our patients reside, and it is clearly the backyard of our facility, our hospital. So then what are the bridges between place and health? And I will just say, as a quick tangent, during my ramblings around Seattle, I think this is the Fremont Bridge. Is that right? So I did not know that before I put this in, but I was able to walk over this bridge, and I was very excited. And so it was nice. I didn't see the troll because I didn't want to get run over by a bicyclist. But yes, so bridges between place and health. We just saw all these pictures that showed, some positive, some negative, some health promoting, some potentially health impeding factors. But what are those bridges, and how might we think about them in ways that could drive action? And I'll start by saying the intersection of place and health is far from a new concept. So this is Hippocrates in the 5th century before the Common Era, wrote in a piece entitled On Airs, Waters, and Places, quote, "The waters which the inhabitants use, the ground, whether it be naked and deficient in water, or wooded and well watered, whether it lies in a hollow, confined situation, is elevated, cold, in the mode in which the inhabitants live and what are their pursuits, going on and on about the importance of where one lives to how the populations, the inhabitants, live their lives and experience health and well-being. So certainly not a new concept if Hippocrates was talking about it 2,500 years ago. If you fast forward a number of centuries, you get to early links between health and place by looking at overlays on certain maps. So I imagine many of you have heard of John Snow and the famous cholera map of 1854. He was preceded by another Englishman, Edwin Chadwick, in the 1840s, who began to overlay links between life expectancy, cholera, respiratory deaths, and exposures like poverty. And this is actually a map from Leeds that was produced by Chadwick in the 1840s that began to illustrate the associations between neighborhood, or in this case, block level poverty, and certain outcomes like life expectancy. And of course, he was followed not too long thereafter with the famed cholera map, identifying the Broad Street pump as the source of cholera infections. And you can kind of see that, I don't know if my arrow, there it is. This right here is the number of cholera cases on that Broad Street right there that emerged from infections at that particular water pump. Now, because these connections are well demarcated, there's been a long debate in public health about the concept of composition, the difference people make to places, versus context, the difference places make to people. And in my mind, and actually in this book that Kawauchi and Berkman edited, they note that this is probably a false dichotomy, that truly it's people create places and places create people, and the two move in both directions consistently and routinely. And because of that, I'd suggest you could take it one step further. Those people and those places create outcomes and outcome distributions, distributions that might be equitable or distributions that may be inequitable. And so these, of course, are relevant to a few more definitions that I wanted to share, the first one being population health. I imagine many of you have seen a version of this definition. This particular one comes from this paper by Knigget and Stoddard from about 20 years ago, where they describe population health as the health outcomes of a group of individuals, including the distribution of such outcomes within the group. And I highlight the word distribution because it's one thing to say that on average, the health outcomes of this population are good, bad, or indifferent. It's another aspect of the term to think about what the breadth of variance within that population might be. This is, of course, related to some of the work that I do. I imagine some of the work many in this room do around population health research, which explicitly studies the conditions that shape the distributions of health within and across populations, and of the mechanisms through which these conditions manifest as the health of individuals. So conditions, distributions, and mechanisms. And so another definition, this one central to that concept of conditions, is social determinants of health. So the definition on the left, yes, your left, comes from the World Health Organization. The conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. And I asked you to remember a phrase earlier, with neighborhoods being the places where people are born, live, grow, work, age, worship, highlighting the intersection of these social determinants and this definition of neighborhood. I also wanted to show this diagram on the right. This comes from Health and Human Services using the so-called vital conditions framework. This is a new way many are looking at and striving to understand the social determinants by highlighting those conditions positively framed that could lead to better and more equitable outcomes. And you can see some of the components on this figure there. A thriving natural world, which you have aplenty here in Seattle. basic needs for health and safety, humane housing, meaningful work and wealth, that concept of opportunity, lifelong learning, the importance of education, reliable transportation, and one that I really like that shows up in the middle is this sense of belonging, the sense of civic muscle, this sense of pride in one's community and contribution to that community. These are the vital conditions for health and well-being. This concept of distributions, as I mentioned before, is central to the concept of health equity. Another definition, this one from Robert Wood Johnson Foundation, highlighting the concept of health equity as the state in which everyone has a fair and just opportunity to be as healthy as possible. And although I won't read the entirety of the rest of the definition, you see that it goes on to highlight the importance of removing obstacles to health, like poverty, like discrimination, like structural racism, that leads to those vital conditions for health and well-being. And then mechanisms. Some of this has been some of our early work to try and understand what underlies differential outcomes. So here's some data that I'll share. This data comes from all hospitalizations at Cincinnati Children's and Mercy Kansas City. And what we did was looked at hospitalization rates for so-called ambulatory care sensitive conditions. You can see those conditions along the first column. And then we calculated hospitalization rates in sets of neighborhoods that were defined according to the Child Opportunity Index. So the Child Opportunity Index is a multivariable score that is available for census tracts, neighborhoods nationwide, that highlights the degree of child opportunity based on domains like education, health and environment, and socioeconomics, and provides a measure by which you can characterize a place, a neighborhood, as either low, moderate, or high opportunity. So in essence, what we saw was a staircase-type relationship between child opportunity and hospitalization rates across each of these conditions. So less important than looking at the individual numbers is the patterns. For every condition that we assessed across 2 cities, the very low opportunity neighborhoods had the highest hospitalization rates, stepping down to the lowest hospitalization rates in those very high opportunity neighborhoods. So some of the mechanisms that potentially could underlie why we're seeing adverse, inequitable distributions of health outcomes. Here's looking at it a slightly different way. This is just Hamilton County, Ohio, which is the metropolitan area for Cincinnati. And this is looking at all-cause hospitalization rates to our center. The x-axis is a hospitalization rate normalized by population, and the y-axis are all 80 or 90 neighborhoods that make up our county. And I don't know, not too many people in this room probably know a ton about Cincinnati neighborhoods, but if you kind of came up with your magnifying glass and looked at the individual names, and you knew of Cincinnati neighborhoods, you'd probably notice some patterns that would make sense to you. And when you look at underlying data that characterize those neighborhoods, the quartile in gray, pink, blue, or green, and their association with certain census variables, you see a very similar pattern to what I shared with the Child Opportunity Index. So this set of box and whisker plots looks at the distribution of a series of variables across these neighborhoods, variables that are obtained from the US Census about these various communities. And you can see what some of these variables are. Educational attainment, vehicle access, child poverty, measures of housing, all illustrating the degree to which these underlying factors, illustrative of the social determinants of those vital conditions, differentiate themselves across neighborhoods that experience elevated morbidity to lower morbidity. And because in this country and in cities like Cincinnati, you can't disentangle the socioeconomic and social determinant discrimination from racial segregation and structural racism, we also see this stepwise gradient with respect to racial composition within these particular neighborhoods. So I want to talk about that a little bit. How can we think of the impact of structural racism on health outcomes, on inequitable health outcomes? And I want to do so by thinking a little bit about the legacy of racism. Now, I imagine many in this room have seen this particular map. If you haven't, I think it's important, insightful to look at. This is a redlining map of Seattle. Now, I admittedly don't know much about Seattle, but I always think it's interesting when I visit cities to look at redlining maps of the cities and to understand a little bit about what that distribution looks like at present time. And for those who are interested and not seen this site before, this University of Richmond site, hyperlinked at the bottom, is incredible. It has a library of all sorts of redlining maps for all across the country when they are available. And this particular map comes from that library of resources. Now, you might look at this redlining map and say, the neighborhoods in red kind of mean this to me, those in green and blue mean this to me, but I think it's instructive to put side by side with this redlining map a map of life expectancy in Seattle pulled from recent CDC data. And again, not knowing as much about Seattle as likely all of you, I'm struck by the fact that we're currently sitting up where you see the H in a rather green area with a life expectancy of 85 years. And not but a few miles to our south is a life expectancy 12 years less in neighborhoods that are more on the red side. And if you draw some lines between the redlining map from 100 years ago, or almost 100 years ago, to our life expectancy data today, you can see some real correlations. And the text here comes directly from this University of Richmond site, detailing how these particular areas were viewed when these maps were created. So if you look at the area around Seattle Children's, this area is one of the most popular residential districts in Seattle. Residents are professional, they have choice property, homes are generally less than 10 years old. You can see very positive aspects of language that are propagated through this documentation. And it's very different in the red-lined neighborhood that has still this life expectancy far lower than what it is today, composed of mixed nationalities, occupied by tenants in the vast majority, homes generally old and obsolete. So language that aligns with the color of this particular map, and it's linked now decades hence to the life expectancy gaps that we see today. We've also wanted to do some evaluation of this. What are the potential effects of structural racism and marginalization on health outcomes? And so we recently did a study that sought to quantify inequity mediation by characteristics of places. And our unit of analysis for this particular project was the census tract or neighborhood. Our outcome was hospitalization rates, again, measured at an area level. And our exposure, also measured at an area level, was essentially racial concentration. So the percentage of individuals who identified as a member of a marginalized racial or ethnic group. And our results found that for every 10% increase in this membership, the tract level hospitalization rate increased by 6.2%, so a rather linear upward relationship. But when we adjusted for a variety of social, economic, and environmental factors that characterize these places, all that relationship went away. So it explained nearly 100% of that relationship. In our minds, implicating and explained by the harmful effect of propagated racist structures and systems that have occurred over decades. There are other consequences of marginalization, and this is a bit of an aside, a bit of a tangent, but I think an incredibly interesting paper from a few years ago that highlights additional consequences of marginalization, particularly in the run-up to elections like the one that will come our way in but a few months. This particular paper by Rodriguez and others looked at excess deaths among those who identified as Black between a given time period, and did so to approximate the number of votes that would have been lost among those of voting age in the 2004 election. And they calculated through this analysis that there were likely 1 million or more Black votes likely lost from premature death, highlighting, again, the lasting consequences to neighborhoods and communities with respect to how we think about policy, with how we think about investments in certain communities. This degree of consequence of marginalization that is cross-generational. Of course, this should push us, though, to think how we can learn from our history, from our neighborhoods, and from our communities to enact the overdue change that's so necessary. So here's a quote from a resident of one of my neighborhoods that means something to me. So Mr. Rogers was a Squirrel Hill resident in Pittsburgh, and he noted that in every neighborhood all across our country, there are good people insisting on a good start for the young and doing something about it. And I think many people in this room are those people insisting on something better for our patients and their families. And so how can we think about a move toward action, a move toward excellent and equitable health outcomes? Some of the things that we've thought about at Cincinnati Children's as core drivers, or in the lexicon of quality improvement, the key drivers of the pursuit of excellent and equitable health include the importance of meaningful, trusted relationships across the health system, a fully embraced culture of equity that approximates that of safety or quality, addressed social and structural determinants of health that enable one to experience those vital conditions that can move in the direction of better health, activated, accountable, aligned leadership within our health systems and across the community, integrated, optimized medical and social care, so rebalancing our approach to what we do with medicine as well as what we do to foster health-promoting lived environments, promoting this concept of systems thinking, action, and learning, that it's impossible to disentangle health from other aspects of the larger system, while understanding that there are variable senses of capability and capacity that can sometimes stand in the way of meaningful action. And lastly, I'll just highlight this one, this concept of translational population health and health equity research, which is something that we've tried to think about quite a bit to build our knowledge base about how to best enact the change that we seek. And one of the ways we've thought about this particular concept is how can we link it into our conceptual model, so to speak, of translational research in general in the medical sphere. What does basic population health and health equity science look like, all the way up to efficacy, effectiveness, and impact at scale? How can we use those basic science building blocks to enable us to devise innovations, be they specific interventions or treatments, policies or processes, that allow us to move progressively forward in this process, while also thinking about what are the new questions worthy of inquiry and improvement that may emerge as we're thinking about different conditions or different populations. And so just as an example of building blocks, one of the places where I think a lot about during my own research is this concept of geographic information systems and characteristics of neighborhoods and communities as some of those core building blocks. So a few terms that are relevant to the thinking here. One is this concept of geographic information systems, where we bring different types of information together in ways that capture, store, analyze, manage, and present those data in ways linked to a particular location. This is, of course, linked to the concept of geocoding. Some of you may have heard this term. It's essentially the assignment of a code, usually numeric, to a geographic location. I've referenced census tract a few times today. Census tract is perhaps the most commonly used census geography in public health and clinical research. The problem with census tract is I imagine none of you in this room, myself included, could say what your census tract is, what the 11-digit number is that characterizes your census. You probably don't know. That's okay. Everybody probably knows their zip code. Zip codes can also be quite useful in this frame, but it should be we should remember that zip codes are defined according to the U.S. Postal Service to make it easier to deliver mail, not necessarily to characterize the socio-demographic characteristics of those in residence. Now, each of these geographies can be characterized on a map as what we call a shapefile, which is a type of file that describes certain geographies. Some of those may be points, where you live, a latitude and a longitude. Some of those may be lines, like roads, railways, rivers. Others may be polygons, like a zip code, a census tract, or a neighborhood. And each of those can then be connected to what we call geomarkers, those objective, contextual, or geographic measures that could influence or predict the incidence of outcome or disease. And so an example of how we're developing geomarkers to inform our questions and our interventions is through this pathway. And it starts at the top with this concept of a hospitalization or a clinical encounter. That clinical encounter is connected to both a date, a time, as well as an address. We're able to join certain data elements to that encounter based on time and general location that may vary over the course of a year, markers of weather, air quality, pollen counts, or mold. We're also able to join those data based on location to census tract level variables, some of which may be combined together into indices like the Child Opportunity Index that I shared before. Others might be more simple and relate to something like the poverty rate for a given area. Some of those data may be able to be formulated at the point level. So where you live, its proximity to green space, its proximity to traffic-related pollution, its distance to hospital. And still others may be formulated and connected to a different geography. And this particular one is parcel, so the plot on which a building or a housing unit might be located. We've started to use this geography to enable linkages to our county auditor page to assess for home value, for liens, for evictions, as well as to publicly available health and building department databases that highlight housing code violations on site. And it's through this analysis that we're starting to assess for links between those parcel level conditions and health outcomes. So here are some preliminary data assessing the time to first emergency department visit or hospitalization for kids from asthma based on living in a parcel that had had a housing code violation in the months prior to the encounter. You can see our preliminary survival plot on the right of this particular slide. Suffice it to say that living in a housing unit that had had a code violation in the preceding 12 months was linked to a nearly 40% increase hazard of showing up in the hospital in exacerbation. And we see there to be potential in this informing anticipatory guidance, enabling us to talk more effectively about disease control and trigger avoidance with families, while also prompting proactive connections with those who might help, those who might elevate the social or environmental treatment alongside the medical treatment. And that, in many respects, includes housing advocates and sanitarians. And then I emboldened attorneys here because one of the areas that we've spent a lot of our time working in terms of clinical community partnerships is through a medical legal partnership. And so I wanted to just mention that briefly. Our medical legal partnership is called the Cincinnati Child Health Law Partnership. And this includes about 1,000 referrals a year from our primary care centers and now our subspecialty care centers to lawyers, paralegals at the Legal Aid Society of Greater Cincinnati who are poised to help with housing conditions, housing instability, threats of eviction, public benefit denials or delays, unmet educational needs for kids experiencing learning disabilities, threats of expulsion from school, all things that are social needs but also have a legal bent to them. And we recently evaluated the effect of referral to child help for kids on hospitalizations. And the figure on the right shows essentially a difference in differences analysis between those who were referred for this service and those who weren't. This wasn't set up as a randomized control trial, so we had to do some propensity score matching and subsequent adjustment. But the analysis led to this reality that referral to this particular program led to a 38% decrease in the likelihood of hospitalization. So a social, or in this case, legal intervention affecting a health outcome. It's also allowed us to develop some pattern recognition approaches, ideally moving us more in the direction of that impact at scale, that translational aspect of this population health and health equity work. And we've used mapping and geospatial analytics to do that. So this is a map of the city of Cincinnati. The cross-hatching are essentially city blocks. And if you just looked at the orange there, here's a satellite image of what those blocks look like. So a few blocks of the city. And we've used this to identify the blocks of the city that are disproportionately representative of those with building and health code violations, as well as asthma-related emergency department visits and hospitalizations. So the orange rectangles here represent those blocks that are in the top 5% of both of those variables. And we have other versions that have looked at this with slightly different levels, but by and large, you can start to see what this map looks like and start to think about how this might approximate the John Snow Broad Street cholera map. Where might we start? Where might the origin of these hotspots be, and how might we address them? And importantly, it's leading to some population level action, building bridges between housing and health data in ways to more effectively address clusters of adverse housing and health. So here are 3 screenshots of articles from lawsuits that the city filed against bad actor landlords in Cincinnati that have resulted from overlays like what I just shared, highlighting where there are violations, where there are landlords who are not upholding their end of the bargain, and where there are kids living who are suffering from those conditions. And each of these particular lawsuits is currently working the way through the courts, and we're trying to do our part as the hospital to elevate the relevance of child health within those building complexes. We're also trying to think about how neighborhoods could find their way into quality improvement. So this is work that we did a number of years ago in 2 Cincinnati neighborhoods, Avondale and Price Hill, to try and explicitly name a smart aim to reduce the number of bed days and hospitalizations for kids from these 2 neighborhoods. We put it on a statistical process control chart here, measuring that rate over time. We pursued a variety of strategies linked to our shared drivers, proactive outreach, more equitable resource deployment, some automated alerts that led to huddles whenever these children were hospitalized, and more complete clinical community partnerships, leading to what we think to be a meaningful decrease in the experienced days, experienced hospitalizations, cutting that rate by cutting the gap with the rest of the county, which is illustrated by the dotted black line, by nearly 50%. Now, these are 2 neighborhoods. We have a much larger city than that. And what we really need to do, what we really want to do, is move in the direction of sustaining, scaling, and spreading our innovations and our improvements. And so how do we do that? So the last little bit here, I wanted to highlight the ways in which we are approaching that push towards scale. And I would suggest that scale starts with a shared vision. So this comes from our strategic plan, from the Cincinnati Children's vision statement, where we strive to be the leader in improving child health. We do so by seeking excellence in the 4 C's. They all have to start with the same letter: care, community, cure, and culture. Community factoring centrally into that particular definition. One of the things that I'll highlight with our vision statement here, to be the leader in improving child health, our CEO, our board often says that nowhere in this statement is the word health care, that we focus on health, and that may point us in directions other than just our clinics and our departments. When I looked at the same notation for Seattle Children's, I noticed something similar. It says provide hope, care, and cures. You have 2 C's, I suppose, to help every child live the healthiest and most fulfilling life possible. And one could say the same thing about your vision statement, that nowhere in there does it say health care. Care is in there much like it is for us, but the bold statement is about health, about fulfilling life. And so that should push us to think about where can we act on that vision, and how can we do so by understanding our population and aligning our approach to that population. In Cincinnati, one of the ways that we're doing this is to think holistically about our population. There are about 500,000 kids in our primary service area. About 120,000 are now insured through a Medicaid accountable care organization structure, a value-based structure that allows us to test innovations that perhaps before in a fee-for-service model would have been trickier. We also have a Child Health Equity Center, the Fisher Center, which is focused primarily on 10 of our most structurally disadvantaged neighborhoods. And there's sizable overlap between these populations. So we're trying to think effectively about where we share in population, how we might overlay mission with margin, to think collectively about an approach that could work with the Medicaid populations and our neighborhood partners centrally located within that set of missions. We've also sought to use a certain type of method that supports learning with community and for equity. We are very much a quality improvement shop. That includes this concept of learning networks or learning health systems, which are organizational interventions particularly well suited for complex challenges that bring together a diverse set of views and insights to drive toward improvement. A couple years ago, we wrote a piece about how learning health systems, commonly deployed toward certain conditions or subspecialties, could be adapted for the pursuit of equity. And the 7 core practices that emerged from our experience, from the literature, from our partners, was the importance of establishing principle, that shared objective, measuring for equity, ensuring that data are available to drive, evaluate, and sustain success, to lead from lived experience, and this includes ensuring that people with that experience are a central part of the work. This concept of co-production, designing, creating, learning, acting, doing everything together, which sometimes requires us to redistribute power. When is something within the realm of the hospital? When do we need to allow a different sector or set of individuals to lead? Practicing a growth mindset, cultivating that environment for learning, and importantly, engaging beyond the healthcare system. Now, this concept of co-production is central, and one of my colleagues, Carly Riley, and partners at Design Impact, which is a design firm in town, highlights the importance of using this approach where key members of the system work together, sharing their influence, but also their skills, to truly design, own, and analyze outcomes and solutions together. And this Equity in Co-Production guidebook has been quite useful for how we've advanced our efforts. And if anybody is interested in that, send me a note and I'll make sure you can get a copy. It includes tools and best practices for how to actually put co-production into practice. I also was struck as I was preparing this about co-production in action here in Seattle. And I've long known and admired the Odessa Brown clinical setting, but I read a little bit about Odessa Brown, the person, and was struck by the degree to which she represented co-production occurring decades ago, highlighting her work as a community organizer for the Central Area Motivation Program, expressing the needs to the planners of the Seattle Model Cities program, and described as this quiet, private person, but when she spoke, people listened, particularly when it concerned healthcare for children. And what we found in Cincinnati is very much echoes of this, that the power of the voice of our partners, of parents, of children, goes a long way towards affecting the change that we need in our own backyard. We also emerge from a shared outcome, a shared vision, to action via shared principles. And a lot of these come from some of what we've learned, and they may look familiar, this concept that equity is central and foundational. Children and families are at the center of our work. We work together on solutions, building relationships and trust, this concept of humility in our work, that we all have something to teach, we all have something to learn, and we continuously focus on results. One of our approaches recently that's institutional is something we call the Health Equity Network, which brings together teams from across the hospital, each focused on an equity-oriented quality improvement aim. We have a shared global aim and a shared SMART aim. Our focus is reducing hospitalizations and doing so in equitable ways. And we have some key process measures that different teams form and different teams seek to move, improving along an IHI improvement scale, testing, learning, co-producing with families and partners, and referring to some of our key clinical community partnerships. And the concept here is that although teams and conditions differ, asthma is not depression, is not diabetes, is not sickle cell, but the drivers of the equity gaps are likely to be the same regardless of the condition that you're treating. And so from this has emerged some shared theory and shared drivers that, again, we think are going to be important no matter which population that we're serving. Access is going to be important. The sense of needs being met, the vital conditions being met for children to be able to thrive, connections between key members of the system within Cincinnati Children's and then also with our community. Of course, the importance of trusted relationships. And lastly, this thought that we learn by doing, that we don't know all the answers. The published literature is not flushed with answers about how we can solve inequity. So we need to learn by doing and bridge those learning divides as we go. And we speed up testing and learning by aligning with priorities inside the hospital and out, by building those cohesive partnerships, by transparently sharing data, and by providing some additional resources to teams who want to test something that may be difficult to do with their resources alone. We bring teams together multiple times over the course of the month, sometimes for teams to share what they're working on, what's going well, what's going poorly, what they're trying to do next. We also have what we call longitudinal solutions labs, where teams working on similar concepts, social needs screening and response, language access, partnership with legal aid, to try and understand how to move that work on more quickly. And we're starting to see some good results. Here's a Health Equity Network team focused on asthma. This is the subgroup of our asthma population that is shared by our pulmonary clinics and our primary care clinics. It is a particularly high utilizing, difficult to treat cohort of about 300 or 320 patients that are predominantly African American. And you can see that they're seeing an overall decrease in hospitalizations within this group, and the lines between these two, the top line being Black patients, the bottom line, all other patients within this cohort, are starting to approximate one another. And this aligns with about 5 fewer hospitalizations per month among those patients, driven by some of these factors that could be impactful, again, regardless of condition. Similarly, our adolescent medicine team has been focused on mental health related admissions, and since they started their work in 2022, we estimate nearly 70 fewer hospitalizations having occurred through alterations to their processes that different teams are now starting to approximate. And when we look at it as a system, here is a chart, this is a moving average chart that looks at admission rates for Black youth in Hamilton County, that's the orange line, and all others is the blue line. in our baseline, this was admittedly pre-COVID, we saw a significant gap, the orange line 1.56 times that of the blue, largely driven by some of these common reasons for kids to be hospitalized. After we began the Health Equity Network with 4 teams, we've seen some narrowing of this gap. We expanded to 10 teams, saw a little bit more narrowing, and are set to expand to 17 teams this academic year. And they formally launched their work a week or 2 ago, and we're going to advance them along their pathway. We're working with 5 so-called bullpen teams, which may join either later this year or next. And then we're also trying to integrate representatives from the Cincinnati Health Department and the Ronald McDonald House, who are also thinking about equity and what their contributions could be as so-called external Health Equity Network teams. We're trying to develop a shared dashboard with measures that are easily disaggregated by a range of factors that allow us to more effectively as an institution understand what our measures look like, and then also expanding beyond hospitalization to think about measures of patient-family experience, school attendance and achievement, and a holistic measure of thriving that could occur for kids within the community. Okay, so to conclude, I want to just highlight the relevance and importance of consistent, meaningful collaboration with neighborhoods, with communities for population health equity. And thinking about the importance of place, I found this really interesting and moving quote from Chief Seattle, who noted that every part of the earth is sacred to my people. Every shining pine needle, every sandy shore, every mist in the dark woods, every meadow, every humming insect, all are holy in the memory and experience of my people. Every hillside, every valley, every plain and grove has been hallowed by some fond memory or some sad experience of my tribe. I thought, what better illustration of the importance of place to the general psyche we all have the possibility of sharing. And in this, I see this reality where neighborhoods, where place can lead to premature death. We saw the redlining map and its connection to life expectancy. But so too can those neighborhoods, can those places promote long, healthy, meaningful, productive lives. I also suggest that neighborhood-based assets and connections can tip the balance toward life, health, and opportunity that we seek. And we can fall into the abyss of the metaverse. As we do, the importance of thinking about what our role is, what our role might be in the pursuit of population health equity will often take us out of our clinics, our wards, our labs, into those places where health can occur or potentially be impeded. And I think through this, we can rebalance and potentially elevate the relevance of those place-based vital conditions. We can widen the circle, ensuring the right partners are there to co-design innovations with us. And we can contextualize care, elevating the relevance of place in ways that are capable of pushing us toward optimal and equitable outcomes. So a lot to acknowledge here, a lot of partners in this work in Cincinnati, beyond, so many friends and people I admire here in Seattle, including Ken Griffey Jr., my boyhood hero. And I would love to remain in touch and think about ways to collaborate nationwide, and I'm certainly happy to take any comments or questions that you might have.
I forgot my microphone.
Thank you so much, Dr. Beck. Such an amazing body of work. Molly Groh, I'm a general pediatrician, total fan of the work you've done and have followed it for a long time out here in Seattle. I have a question about you, if you could comment a little bit more about partnerships with schools. Mm-hmm. My sister is a principal of an elementary school in the Midwest, and we talk a lot about the challenges of silos between our systems. And we both care so deeply about what's happening for children and their development and health. And I find that here in Seattle, we've also struggled a bit with making those connections and how to help us flourish in that regard. And I'm curious if you could comment kind of on how that's gone for you all and what you're seeing.
Yeah, it's so important. I think school is of probably all the partners that could be potentially impactful for us, that's probably at or top near or at the top of the list. I would say it's been fits and starts for us. There are certainly longitudinal partnerships that we've developed around measures like third grade reading, sixth grade math, high school graduation, school attendance and absenteeism that have led to meaningful change, meaningful action. And we have several representatives of Cincinnati Public School in some of our community-wide learning networks, including the one called All Children Thrive. One of the ways we've done that is through what we call capability building, which includes quality improvement supports. We have a data analyst who works with schools to help unlock the fruits of their data more effectively. My caution there, and perhaps the thing that drives me the most nuts, is that capability building without capacity isn't all that useful. And so I think that's what's stood in our way sometimes, that, I'm sure everybody knows schools are busy just like we are, and large urban school districts are perhaps excessively busy. And that has sometimes stood in the way of them being able to act on those capabilities. The other thing that I would say in Cincinnati, and I don't know the situation here, but we've been somewhat hamstrung in that in the last 5 years, I think there have been 5 superintendents of Cincinnati Public Schools, and each time there's a new vision or there's new priority areas that can pause the work. I think there's a new one again, though I think is more bought into this, so we're optimistic, but it's fits and starts.
Go ahead.
Hi, Dr. Beck. Thank you for coming here. I really appreciate it. My name is Panit. I'm one of the ResEx for our residency program. I think the central tenet that you shared about co-producing and aligning with experts who are not necessarily in academia is really important. I appreciate that. I'm wondering, in terms of the co-producing with whether it be community-based organizations, community leaders, community organizers, other people who have expertise that are not in this academic circle, what does it look like to compensate people who co-produce with you? And then what advice do you have in approaching that?
Yeah, it's a great question. So my first simple one is, yes, compensate. We've had to develop some policies over the course of the last number of years about that, and currently we do that. So whenever families, parents, community partners, not all community partners, if it's if it's appropriate, they're compensated for their work with us, whether it be in quality improvement, research, attending meetings. We also ensure that we provide transportation for certain meetings. We provide childcare, trying to make it as easy as possible to overcome barriers. But I think the high-level summary is, yes, compensation's a must. They're bringing something to the table. We must bring something too.
I'll just end with this comment from Dr. Coker, who is online with us today. Thanks so much for such an amazing talk and for highlighting how critical it is for us to put communities up front in all of our work in health equity.